in there. I'll ask for apologies first. Paul?
Yeah, thanks, Mike. So we've got apologies from Almin and we just had apologies from Alison Cole as well this morning.
Okay, thank you. And just to let everybody know, chap sitting in the corner here watching, Phil Horner, welcome.
Hi, Phil.
Deputy Chief Strategy and Improvement Officer from the Mental Health Trust on the Nye Bevan programme. So he's observing the board as part of that programme. And I understand with Chris, with your permission as well, Phil can observe the finance discussions we're having later. Welcome, Phil. Okay, and then let's go through declaration of conflicts of interest.
Just one update to make, Mike, and invite Carrie just to give an update. She's got a new role within the ICB.
Yeah, just update. I've got the delivery manager post for urgent and emergency care at the ICB.
I think we'll minute that as a declaration and minute our congratulations to you as well, Carrie.
Thank you.
Thank you. Okay, colleagues, ready to move on? Yeah, minutes of the Board of Directors meeting held on the 3rd of July then. Somebody want to approve its correct minutes? Yeah, great, thank you. Action sheet, I'll move to the company secretary, please.
Thanks, Mike. Yeah, there are just 2 items scheduled for the board today relating to CQC and the other item, which are both listed for today. Computer just froze. Yeah, so the other item that we've got is communication strategy, and again, included on the agenda. That item, Mike, thank you.
Okay, colleagues, you comfortable then if we move on to item 51?
Yeah.
Okay, patient story. We've got end of life care, just to give you the context. You may remember in May we had a presentation. We looked at the importance of communications between families, carers. We heard from Mrs. Parr, and now we've got a follow-up. Emma, I'll ask you to introduce yourself through the chief nurse. Over to you, chief nurse.
Thank you, Chair. So, morning, everyone. So, this story is really key to showcase some of the improvement work we are doing. So, basically, Emma is going to update us on some of the improvement work specific to end of life. So, there you go, Emma Fitton, the Associate Chief Nurse for Quality.
So, morning, everybody. Nice to see you all this morning. So this presentation is around the end of life care, following on from Mrs. Parr's story, but just really to showcase some of the work that's been happening over the last 12 months. So we picked up 3 key themes from Mrs. Parr's story around communication, professional standards and education. So what we found is that sharing patient stories it has the biggest impact on our staff of any sort of education, to be fair, because I genuinely think that staff are not coming to work to do a bad job, but it hits them at the core and they stand and they listen and they take that on board. So we have shared the story with others. We've had previous stories that we've shared with staff, and we are starting to work around the communication and professional standards. There were elements around the nursing staff talking around just 1 minute, and we've looked at that and we've actually started to pick that up now as part of our quality assurance visits, so that we can challenge staff, and also on our senior nurse walkarounds that are every Friday, and to check in with them. Education is huge around end of life care, and I will talk a little bit more about that as we go through some of the quality improvements that have been happening. So there's a lot of work happened. We started off with a quality improvement day, which I know, Susie, you came to that as well, didn't you? So we worked with our quality improvement team, and we had the right people in the room to really start focus down on what was important and what we needed to do. It was supported by the CQI team. They were fantastic with us, and we actually came out there with top 3 focuses of what we need to do. So the first one was around the care of the dying care plan. This is an individualised care plan for each individual as they come into hospital, so we can identify what they need and what their families and themselves wish to have as they approach end of life. We are almost there with that and looking to launch that in the next two months. It's been a great piece of work, and it really is focused about putting the patients at the centre of the care, and what they and their families wish for at the end of life. The other options were around our 7-day palliative care service. So at the moment, we only have a 5-day service. This has been picked up by the community care group. They're in the process of developing a business case, and we will hope to drive that forward in the future. To provide that 7-day service then will also allow us to introduce something called Golden Line. So Golden Line has happened across at Airedale. They've introduced it, and this is a support line for not only medical colleagues but also for patients and loved ones in the community, that there would always be somebody that they can contact, whether that is that they would need medical advice or just someone to support them if they've got a loved one at home that is dying. So they are our top 3 focuses, but they are longer term projects. So there were a few quick wins in there, which we've also picked up. So we've identified that there was issues around syringe pumps and accessing syringe pumps, which we deliver end-of-life medication through. So we're just working through with medical engineers and some of the nursing teams, our processes. What we found is we did have enough equipment, but they go home with people and we're losing that equipment out in the community. So we're trying to be innovative around tagging this equipment and how we could do that, and also an amnesty so we can return that, and then look at our processes about how we follow that through and get that equipment back in place, ready for the next patient as and when they need it. We found that there were issues around, there's lots of work gone on in the community around advanced care planning. So people plan for death, which is the right thing to do. We should all be doing that. We should talk about death openly. But some of our staff were unaware of how to access that information when they come in through our emergency department front doors. So we're doing a piece of work, and what this will do is it's the practicalities of how they access that information, but what it will also do will empower the staff to be able to make those quick decisions that actually this patient doesn't want to be in hospital for their final days. Let's get them home and get them comfortable. And we've been working with NWAS as well as the community services to deliver on that. And then with regards to education, education is huge. So we've been successful in a bid to Health Education England, where we have created a joint post for 18 months with the University of Cumbria, and we are scoping out the education that is available already, but also looking at developing a standardised education for all our staff, and this is in a tiered approach. So this would start from level 1, so this may be somebody in the canteen who could be serving a cup of tea to somebody who has recently been bereaved, so that they recognise those signs and can signpost them into the right directions, through to the portering staff who will be transferring our patients to the mortuary, right up to the clinical director of palliative care for advanced communication skills. So it means that everyone within the trust will have some form of education dependent on where they sit, and to support the bereaved relatives, and trying to make it that end-of-life care is everybody's business. It's not just the palliative care team, it's not just the medical staff. We all need to be aware of it. So that's the work that's happening there. We've also established some multi-agency working. So we've made contact with St John's and St Mary's, and we're working with the ICB, looking at our processes and pathways. And we've started to learn from our incidents and feedback, and what work can we do together as a team to be able to start and unblock some of these issues that are happening. Now, the palliative care team have been working really hard with the ICB around getting to outstanding. So the Getting to Outstanding framework is a self-assessment tool process which was undertaken across the whole of Lancashire and South Cumbria, which does incorporate obviously Morecambe Bay. And it was based upon the 6 national ambitions for palliative care and end of life. And it was to look at what exemplary care looked like for our patients and how would we achieve that. So over the last 12 months, we've done a huge piece of work, a gap analysis of where we're good, where we're not as good, and we have picked up some really good practices. So our do not attempt resuscitation processes are digitalised, which is a step ahead a lot of the other places. So we've got really good ways of working right across the bay. And we've also got pockets and silo pieces of work that are good around single points of contact for some of our district nursing teams. What we need to do now is start and make sure that that's right across the board. We can't just have this silo working. We need to make sure that we're sharing that. But then there were three key focuses that came out of this piece of work. One was that compassionate communities. So we need to support our local communities to talk about death and planning for death so that we can prepare for this. And we have started a piece of this work. We've reintroduced death cafes, which I'll talk a little bit about in the bereavement section. we need to learn from experience of our patients, which we're already doing, and again I will touch on that shortly. And really about how we use our electronic systems more effectively and efficiently so that we can share information right across the board, so that as you come into hospital, we're not starting again. We need to continue these pathways through. So with regards to the bereavement services, just a little bit of information really. So last year, 23-24, we saw over 15,000 deaths. And the bereavement service, which is 2 registered nurses, we actually contacted every next of kin where we had the details for them. There were a small number of public funerals. What we do is we offer support. We are very, very lucky in this area that we've got fantastic charities wrapped around us that we can signpost people to if they need additional support following death. And we also support the families through the complicated things like death certificates and how they access those. The bereavement team are fantastic as well around helping families to gather memories following death. So at the end of last year, we introduced the SWAN model. So the SWAN model is a nationally recognised symbol, and this is about providing dignity, respect and compassion to patients and their loved ones at the end of life. And what we do is we make sure that not only is the patient being looked after, but also the carer that's with them at the time. So there's some, we now offer free parking to relatives who are with loved ones. We've got coffee and cake vouchers. We can provide meals to them and hygiene packs as they need them if they're staying with us overnight. But also what we do is that we provide things like handprints and hair locks and really promote creating memories in those last few days. So things, if you want to bring your dog into hospital, there are no rules to say that we can't do this. So we can try and fix anything, and it's to try and empower staff to think outside the box and what is important to that person and their loved one as they're in their final few days. We've also done a lot of work with Kent Town Palliative Care Team. So this is around paediatric deaths. And we've now created sibling boxes with educational information and age-specific mementos so that brothers, sisters also can be supported through time of death. So there's some fantastic work. We're just innovatively, actually, we've just supported one of our bereavement nurses to complete a yoga training session, and our ambition is that actually we will start to provide yoga sessions for our bereaved relatives. So evidence base is that when you are relaxed, you will receive and retain information that is given to you. So we will provide that session, and that will be supported not only by the bereavement services but chaplaincy services and some of the charities, so that people can just take time out and come and really have time for themselves to sit back and think. So we are in the early stages of that, but that is one to watch for the future that's coming. What else we're also working, as you'll be aware, with the patient experience team. We've worked this last 12 months over really expanding our volunteer base, and we're now embarking on a piece of work to promote volunteers who we can train and provide as almost somebody that can come and sit. So if you have a loved one that's in hospital for a prolonged period of time, you don't want to leave them, but actually sometimes you just need to go and have a shower, or you just need to go and have a cup of tea, so that we can provide somebody, if they wish, so that they can come and sit with their loved ones. And I've this week been in contact with the hospice that we can actually start and look at whether we could then follow that out into the community as well, so that there's always somebody available to them. And then from an audit point of view, to see where our quality is coming from, we're now participating in the NACL audit. So that's the national audit for the care at the end of life. We have participated in this since 2021. And we were above the national standards for 21-22. The one thing that fails us is the lack of the 7-day service. So we're obviously working through that. Now, last year, 2023, they revamped the audit, and they've now incorporated elements so that we can gather information from relatives, their loved ones, staff, so that we can start and gather that information and find out how they are feeling and where they feel we are doing well or not. So we will continue to monitor that over this coming 12 months. Sorry, am I right with time? I'm doing okay. There's lots of work been happening around learning from good practice. So, you know, we're in the process of developing the end of life strategy group, and thanks to Tabitha and Scott and Sarah for supporting us with some of this work moving forwards. And because what we found is that a lot of these incidents and complaints sit within the care groups individually, and actually we need that helicopter view and that theme so that we can really start and drill down in them. We've started to learn from our incidents and patient experience. There's QR codes that goes out with every condolence card. Yeah, huge amount of work happening. So lots planned for the future. The end of life steering group is the big one. We've just drafted the terms of reference that will be coming out this next week for everybody in agreement. We're starting to look at the new CQC quality statements and align those to current practices, and really building on this multi-agency working, because actually it's not just specific to in-hospital. What we're wanting to do is promote that patients can be cared for where they wish to be cared for, which more often than not is in their own home, in their own beds. And yes, thank you very much. Sorry, I've gone over the phone. That's a lack of sleep last night. But yeah, happy to take any questions. I know the big question will be around data, and where is the data for me to be able to demonstrate to you that this is improving. So just an update on that. So what we find with end of life, a lot of the data is actually qualitative data rather than quantitative, so it's difficult to produce for you an SPC chart that shows you that we're going in the right direction. What we are doing is I can produce that for you about, are we doing care plans, are we doing this, but for me it's about, so what? We may be doing a care plan, but are we actually following it? That's what's important. Yeah. So we're just working with our BI colleagues around a dashboard for the nasal audit so that we can continuously track that with the key areas, and also around how we gather those themes from the qualitative data to make those our focus of our improvements moving forwards. But happy to take any questions. Thank you.
I'll open the floor up, Emma.
Okay.
Let's start with Sarah, care equality.
Thanks for the update. It's really good to see this starting to come together now, and obviously given the patient story we heard, as you say, it's the so what as it gets embedded. It's really important. My question is just around the governance route actually. So I believe the end of life steering group will report through to quality assurance. Yeah, and so as that comes through, we can agree the right reporting arrangements so that we can capture both the qualitative and quantitative. So yeah, looking forward. I mean, it's a difficult area, but looking forward to working together on this. It's really important. It's really about patient experience.
And the only thing, Sarah, that I can assure you, I am so lucky to work with the people that I'm working with that are so passionate and dedicated to getting this right. We absolutely hear those patient stories and take them, well, I do, I personally take them to the heart, and we really do have a dedicated team that are driven to make sure that this happens.
Go, Karen. I'll bring you. Karen.
Oh, thank you for that. It's really, really fantastic to hear that. And just a couple of things. That the first is what I was hearing when you were describing that is staff really, really tuning into what matters most at that time for that person and their family, and it's just absolutely critical. And that reflects a kind of change of mindset. It's kind of what matters most to that person. Not what do I need to do primarily. I just wondered whether when you're evaluating, monitoring, reporting on this, there's a way you might capture how that thinking spreads beyond end of life care and just really impacts on how staff are meeting, thinking, responding to patients, people and their families.
I think, Karen, that the SWAN model has made a huge difference, because what we've almost said is there's no rules. There's no rules around this. In the NHS, we're great at setting policies and things are strict and this, that and the other. We dare veer off that pathway. And it's about empowering our staff to be able to actually, these are intelligent, sensible people that, you know, we need to allow them sometimes that freedom to be able to make their own decisions and what's right for that one patient at that time. So I think you're right that this could spread further. I'll probably get sacked now though for saying that. I'm sorry.
I'm with you, absolutely. And just the second question differently is, how does this interface with primary care and all of the end of life support that's happening that never never or rarely that we rarely see?
Yeah, so it's really difficult. So I think this joint working now with the hospices and the ICB, we're really starting to pull that in. We've got William Lum, who is fantastic at this work as well. We've linked in with William. So the big piece of work is around that advanced care planning, anticipatory care planning. And for all of us, really, think about our own mortality and our own death. What do we want at the end of life, you know? And I'll tell Tabitha I want a bottle of Prosecco, but you know, it's just, you know, whatever we want, make sure somebody knows that and that it's written down so that actually we can plan for that. And if we then give our staff the tools to be able to see that written down, it empowers them to then deliver upon it. So
Thank you. Aaron, please.
Very briefly, because Emma very kindly posed my question and answered it for us. It's only a quick one. So just for the board's awareness, because of the work that we're doing on clinical models in the system at the moment, the company that we're working with approached this in quite a different way, looking at which organisation, which leadership teams have shown through evidence that they're leading the way in our system on certain delivery of kind of pathways of care. And Morecambe Bay stands out for end of life. We're going through a workshop this afternoon with that company to reflect that back and with the system. So even though we had the patient story from Mrs. Parr, which was awful and pointed at real gaps in what we're doing, what I like is that even with the plaudits from the system and the very, very good approach that we're taking here, there's some tenacity and some, I guess, connection from colleagues when we hear a story like that to go a bit further to see where the other improvements might be. And my answer then is, when we think about our patient experience strategy and our patient experience groups, that we bring this story into those broader patient experience structures, just to take the learning and the storytelling across. So it's very similar to the point of our spread, but I think we've got a structure that allows us to do that reasonably well. My one question is, we made a commitment to Mrs. Power as a board that we want to listen to her through our improvement journey and take some insights and reflection. And just check that that's happening.
it's part of our improvement group.
Thank
Yes,
you.
yeah.
Thank you.
Will it get fed back to Mrs. Parr? You presented at the.
Yeah,
board today.
I'll let them know this week.
Great. Okay, colleagues, I'm looking round. Mike. Sorry.
It's okay. I think that's really helpful what we're doing, and it does sound rather wonderful. Somebody who's been through that experience and sadly it wasn't quite where I would have liked it to have been. I think sometimes one of the biggest challenging things is actually the family knowing how to engage and where to engage. And you've given some really brilliant examples of how that can happen. How will we be able to be assured that we know that that is actually happening?
Yeah, and I
with
think
the
that will come
family?
through our patient feedback. So it is communication is absolutely one of the key things, or lack of communication is one of the key themes that's coming through the feedback. So I think with that delivery of the education, that actually it's not just down to one person, you know, just, and also allaying the fears, talking about death and allaying fears of talking about death. It's okay to talk about death and we should all be talking about it. So I think I'm hoping, she says with the fingers crossed, that we'll start to see that theme soften as it comes back through the patient feedback.
My follow-up point was that sometimes, unfortunately, these things can happen very quickly.
Yeah.
And it may be that the staff that are immediately involved are not as experienced and haven't had that opportunity.
Yeah.
So how do we allay those sorts of situations?
Yeah, it's that senior support and that and flagging to them as well where that support. You're never on your own. In that hospital, you are never on your own. There's always somebody there to support you if needed. So it's flagging it to them if they feel out of the depth where they go to.
For assurance purposes, the oversight of what you just asked for will go through the quality committee as well.
Thank you.
Ryan?
Just two observations. One, thanks very much for that. I thought it was really, really helpful and encouraging to hear. I think the two questions in my head were around education is a huge issue. What's your approach if people don't engage? And I think that's worth thinking through what your stand and approach would be.
Yeah.
And I think from the quality perspective, there's some data to capture there about how many people who, and how will you measure if it's making a difference? Will that be picked up in the national audit, or will you need to tailor and bespoke the education for the needs of the trust?
Yes, so some of that will be picked up through the national audit. However, I think there are elements for Morecambe Bay that we will need to tailor our education around.
Want to respond as well, Jane?
So I was just going to say, I think we need to work with the new medical school and the current curriculum, because I never had any end of life training. I went into a specialty where it became necessary and I got that, but not every specialty will have had that. And so I think we've got a lot of relatively senior people who are probably quite scared of those conversations. And we need to work on that in-house, but we also need to equip everybody that there's been a sea of change, because we've got so many more people who are able to live with chronic, debilitating, deteriorating and ultimately life-ending conditions for much longer. We have nationally to move away from that being a specialty model to there being an element of it being everybody's job. And then there'll be the really niche things that are a specialty thing, and we've got to knit those two things together, but we do need to get it in at a very at a medical school and the nursing degree level, in order that that's part of everybody's routine.
I think that's really important, because that was part of the experience I had. That were there at the end for a little bit, and the explanation was they weren't specialists yet.
Okay. Take Mike and Sarah.
Yeah, thank you. That was a really good piece, really helpful for me. I'm interested in insurance around what the ICB are doing, because a little bit of lived experience, because I've seen firsthand when you're at end of life that you're still being cared for, and you're going across trusts. You go to one site for one bit of treatment, another site for another, or to try and ease the pain. What's the overview that the ICB is taking? Is everybody heading towards being on the same hymn sheet?
Yeah, I think that that's what the aim is, and the Getting to Outstanding framework will pick that up and work right across the board. So I can't give you much detail because I'm not directly involved. I think you're going to say something.
The Getting to Outstanding is a project that was carried out across the system, so with the ICB. So they're part of some of what has been presented today. So we're kind of working as a system, working together to make sure we get the end of life where it should be. So the initiatives we're doing in-house, but there is also work which is being led by Sarah Price, who is our end of life consultant lead, and she is amazing, to be fair. And some of what Jane has said in terms of changing mindsets about people being able to not being a doctor and want to treat, they have to acknowledge that somebody may be reaching end of life, and that's being done across the system. And Sarah is our lead. Sarah Price.
And just to add one thing to that, so the work at the ICB and the work within the end of life care group is based around the 6 strap lines, I guess I want a better phrase, of the national end of life plan. So we look really keen.
Yeah.
Sarah, last point.
Yeah, thank you. It was actually prompted by your comment, Jane, actually about that clinical engagement. So just in terms of thoughts for the steering group, and then how we work through in terms of the education. Obviously, as you mentioned, Sarah Price, we know as a clinical lead is a real driver for this, but actually it's going to be about the rest of the medical workforce as well, isn't it? So how are they being engaged in this process?
So we've actually been involving some of them within the NACEL audit, actually, so that they're getting involved at early stages at seeing what we do well and what we don't well, and that's down to the FY2s. So and we've been inviting them also into the improvement group so that they can be part of that to drive it forwards. I know Sarah beats the drum very loudly. She's fantastic. She's fantastic for end of life care. So I don't think there's any escaping her, to be honest.
No, there isn't.
I think the end of life steering group will be really key in
It'll be
this,
key,
and I
Close
think
to
we've
you.
taken the view of let's start with something,
Yeah.
and it will gradually grow. And so we may not have all of that care group input at the beginning, but we'll, in 3-6 months' time, when we've got a little bit straighter about the priorities, then we will draw the right people.
Great, that's really good to hear. And again, we'll see that reporting into policy, so that's really helpful. Thank you.
So to summarise, Emma, from the discussions, there's work to be done around education and training, which is in course. There's work to be done around the new medical school, Jane, and working with the university around end of life care. Quality subcommittee will receive reports and will oversee the steering group. So we've got an assurance pathway. we're going for the kite mark of outstanding and bringing in the SWAN model, for want of a better word. So I guess the next step for us as a board around assurance will be to allow the quality subcommittee to then do its job and escalate anything that's relevant to the board. But you're welcome, as you know, always. So if you want to update the board, have a word with Tabitha. I'm sure they'll speak to the COSEC.
Yeah, it would be nice to update you, once this work's up and running, that we can assure you even more that,
We can do it through Tabitha and the
Yeah.
COSEC, or you
Yeah.
can do it through Sarah as the chair of quality.
much appreciated. Thank you. Thanks for your support, everybody.
Thank you.
Well done. Yeah, thank you. Yes, you.
Yeah. You've got to back your back.
Oh, now. Yes.
Yes, sir. Okay, colleagues. We will come back to this. Sarah, we look to you as chair of quality when you're ready to give us an update, maybe, let's say, January, February.
I think it's sort of a 6 month.
Where it's settled.
Yeah.
Next item then, item 52, chair's report. You all got it. We've got quite substantive items that I want to get to, so I'm happy to answer any questions. Otherwise, I just give you the chair's report to note and accept.
Yeah.
Colleagues, you okay with that? Then we'll move on then to the chief exec's report. Lauren, please.
Thanks, Chair. So just brief update from me this month. I was saying to a few colleagues this morning, it's an unusual period, the July, August, because it tends to feel operationally it isn't quieter, but in terms of the key pieces of work regionally, nationally, it is a little quieter. I had the opportunity to go to a national chief execs meeting yesterday where we had the pleasure of meeting with the Secretary of State for an hour or so. And you can certainly sense now what generally happens in September, October, lots of things start to reignite, like planning guidance and strategy work, etc. So I can give a brief update on those. So from a national position, you can see two clear work streams that we will engage in on both. The first is the Lord Aradazi review of the current state of the NHS. You'll have seen the new government Secretary of State has commissioned independently Lord Darzi to do the review. We received some broad headlines from how that's shaping yesterday in a separate session with the report due later this month. It's due towards the end of September. That piece of work is designed to inform a new 10-year plan, a 10-year strategy for health and social care. And again, yesterday we got some insight into the timescales and the process by which that will be conducted, with a view that a final proposal for a 10-year plan and some delivery objectives for systems in the spring of next year. And you can see the ambition, I think, is to land the diagnostic, if you will, in September ahead of the October spending statement, and then to land the 10-year plan in the same timescales as the spring budget. You can see they're trying to align some of that to get some support longer term for what might be needed out of those two pieces of work. What was really interesting yesterday was the process by which the 10-year plan will develop. Lots of deliberative events, patient forums, system work, lots of focus on creating a more healthy and flourishing population. You can see the population health, public health agenda feature loudly early in the way that we want to construct that. Very little in acute service configuration, etc. Although it's acknowledged that's likely to be needed to satisfy some of the assets in the diagnostic. So really pleased yesterday to see some of that more granular what, by, when, who, how people will engage. Once that's launched more widely with key dates, Chair, we'll make sure that any opportunities for the trust, the board, the system to contribute to that programme of work will circulate. We'll make sure we get colleagues alongside that. The other track then is very clearly around the here and now. So winter, elective recovery, financial performance, some facilitated sessions around what's going well in systems from kind of reflections of previous winter and some things we might want to share and spread, and some risks and concerns. All of the risks and concerns are predominantly around a couple of areas which I'd expect us and know we are also looking at. It's the issue around vaccinations and what might happen with Mpox, RSV, COVID and flu. So we need to make sure that all of those opportunities for us to make sure we've got as well a population and as well a workforce as possible, we are taking forward. The other is the financial pressures in the system and what that might mean for capacity and what we do. We've got a winter plan update from Scott later on the agenda where that will feature. So nothing to share specifically, only to recognise that the core performance is another key area of focus for us. From a system perspective, I'd like to take the opportunity to welcome Emma Woolett, who's been announced now as the new chair of the ICB, started last week. I think Emma's on a couple of weeks annual leave, so we'll start visibly in a week or so's time. We also have a couple of areas of focus in the system. We are participating in the inspection and intervention regime, the financial oversight regime, and Chris has updated on that previously. We'll spend a bit more time on that as a board later on today, Chair. We've also made an appointment in the Provider Collaborative Managing Director, which is a post we've held vacant for nearly 12 months now, but Jonathan Wood is currently the Chief Financial Officer at Lancs Teaching Hospital, starts next Monday on the 9th. Really looking forward to the work that the Managing Director can help us in shape, particularly. There's no lack of awareness, I don't think, across the providers about where the issues are and even what the programmes of work are that we need to achieve to resolve those. But we do lack a bit of firepower in the coordination, the kind of getting key decisions made, the pace at which we can get into solutions. The Managing Director is going to play a key role with the PCB and the ICB in helping to structure a way of working that gets us to those more quickly. Obviously, there's also the alignment of preparations for winter and the financial oversight. From a trust perspective, again, I won't cover off everything that's on the agenda, but clear focus on winter preparations, clear focus on financial improvement. We've also continued the piece of work that we briefed the board on earlier in the summer around the care group realignment. That consultation process is now completed. There's a big piece of work tomorrow to receive all of the consultation responses, both from one-to-ones and through the mailbox. What I'm really pleased to see is the level and type of consultation response we've seen thus far means we're going to have a 2-week period to really consider that and come with an alternative proposal, likely from the feedback we've received. So that has pushed us back 3 to 4 weeks in terms of taking account for that and then seeing what the final proposals look like. The board will get some sight of that, Chair, as it reaches its conclusion. And the final piece, I would just feedback from the board. You can see it in my report. We're at that time of year where we start to triangulate further feedback on whether our improvement work is continuing to have an impact or not through the inpatient survey results. So we've had 3 lots of results in this last few weeks. So the National Inpatient Survey, some specific survey results from our cancer services and maternity. And what I can say with an evidence basis, we can triangulate patient experience in those areas with the improvement work that we're seeing at the board, both in terms of the areas we've seen improve, particularly service improvement, quality and safety improvement, and the areas that we know we still need to improve. It's predominantly around communication, engagement, that listening, that reflection, that taking on board patient-specific views around care planning and diagnosis. When I say that, we are within 1 or 2 percentage points in the high 80, high 90%, but they stick out because they're not as good as the other areas that we can demonstrate. So what I really like is that tenacity of following through. Well, okay, well, we need to push in those areas now as well. So we'll take the reports as a summary of my report, Chair, but there will be further work, particularly at the quality committee around actions around those. And in a few minutes, Chair, that's my updates from that.
Thank you. Any questions for the Chief Exec? Tony?
Yeah, thanks, Aaron. That's really helpful. Just going back to the national event, there's a lot of conversation actually about devolution deals, which I know is a broader economy and system. But was there any reference about ICBs and future kind of perspectives in terms of what? Because you hear a lot or read a lot about the future of ICBs. Was there any reference to that, or was it all?
There was. So I need to be mindful of the context in which the conversation was held because it was confidential. But the broad strokes were actually the structures feel about right. That kind of giving more empowerment to regional areas and trying to keep decision making as close as possible to where the services are being delivered. I think there was a reflection of how effective are they working currently, and I think some reticence to talk about further structural change to resolve any issues. So I think I'm okay in sharing those key themes. So there was definitely no conversation about another restructure, but a definite commitment to making sure that we're getting the decision making as close to the front line as we can. There was also a conversation about actually in some circumstances it is fair and reasonable to hold something centrally and get a common and consistent mandate. So broad themes. I think the new government in place for 8 weeks, and the 10-year plan is going to be the vehicle in which some of these things are considered. But there were some early themes that featured yesterday, but nothing specific.
I mean, that's really helpful because from my perspective, because too much time spent on restructuring and not enough time on doing it.
Okay. Are you happy to accept the chief exec's report? Take into account there'll be a number of follow-up issues, particularly the papers that will come to quality.
Yeah.
Okay, colleagues, and we'll move on. I'll invite Susie Hayman to give her first lead governor report to us. Welcome, Susie, over to you.
Thank you, Mike. Obviously, the report I've given as read. Just to add that in my list of things I'm going to be doing in the future, I've also joined the board subgroups, quality and people. Get myself across what's happening. And to tell you that, of course, we're having quite a shake-up in the Council of Governors in the near future, in that we are having new people coming in and people going out. And what I would like to do in the future, perhaps, is to be able to bring you more of a flavour of what we're discussing, what we're worried about, what we're asking in my governance report, which didn't this time because in a sense, there's no point because there's going to be such a change. So I'll report, obviously, in the future on that, and hope that in our development meetings with Tony, comes to something quite interesting. Any questions? Very happy to take any questions.
I'll just take that first point you made. So we've got it in the board minutes as a proposal to the board, if that's all right, Susie. So as the lead governor, you're proposing to the board that in future reports, you'll give us an update on the main issues being discussed and anything you wish to escalate to our attention from the Office of Government.
Exactly, which I think is the point of the call after all.
Colleagues happy to accept that? Yeah, great. So we'll record that in the board minutes. Thank you. And then related to your report, we've all read it. So I'll just check. Colleagues, any questions for Susie on that? No. We're happy to accept it.
Yep.
Thank you, Susie. Okay, CQC item 55, improvement plan update. Chief Nurse, please.
Oh, thank you, Chair. So the CQC improvement plan update is just here to provide an update around the CQC we had in April and May 2023. Where we were saved with 10 must do actions and 11 should do's. And there is a bit of detail because this report has been to PAC, where it's been scrutinized and discussed. And the detail is in Appendix 1, which is on page 64. The pages are similar to mine, which gives progress on ongoing recommendations, what we are doing and where the gaps are. So I'm not really going to go into detail on it, if that's okay. Moving forward, I think we will just bring exceptions from the report because PAC is going to take oversight of this report.
I'll ask Sarah then as Chair of Quality. Anything you wish to add to that, Sarah?
No, so just to confirm, we did receive we scrutinised the report at the Quality Assurance Committee last week, and yeah, so we covered it and nothing to escalate.
I'll open the floor up for questions if that's all right. They're related to the action recommendations following the report. Any questions to the Chief Nurse on those? Karen, please.
Thank you. I just had just one, and it's probably more to the medical workforce. So it's the must do's 2 and 6, and then should do 20. And it's just around the pace of compliance with mandatory training, because we know there's really strong evidence base that the correlation between completion of mandatory training and quality of care. So it feels something that's really important to focus on. And there's just a sense that I think the original plan for completion of the compliance was December 23. So we've just got a time lag around that, and it's just whether there's any more escalation or how we could get more focus on that level of compliance.
We continue to monitor that through performance, but I will take it as an action again to see where the gaps are, and then happy to give you updates, Karen.
I think my sense is it's
not
focused
moving.
around it's not moving, and it's the kind of clinical director medical part of the workforce where we've got a sticking point, and I just wondered what the potential is to
Okay.
Yeah,
give some
sorry.
focus.
can't answer that on the Hoof Pro Go Away, but I can't remember the detail, and Sue might be able to. I think it's one area, it's one component of it, isn't it, that drags the whole of it down. 9/10 of it, I think, are above our trajectory. But we'll pick that up outside because I can't give you a coherent answer. Nothing new.
Thank you. I was just going to say, should we take that back into next quality assurance committee as the update? I think that'd be really helpful. Thank you.
So just for the minutes, so we're clear. So Karen's asked a question. Jane, Tabitha, you're going to do some more work on it, and they're responsible for all through the quality committee.
Yeah.
Thank you. Okay. Sakthi.
Just a quick one, Mike. Thank you, Sarah, for clarifying that. My question was similar to Karen's in the paper. I was looking for when these actions were to be completed by, and it wasn't clear, and I didn't know whether there is a stipulation by CQC to be completing those must-do actions. So you might want to pick that up again through the quality committee. Thank you.
Yeah. Thank you. We'll take that as an action point, Sakthi. Thank you. Okay. Any other issues? We know these actions and recommendations have really only come into force because the CQC came in July. So we look to the quality committee then to oversee and provide assurance escalate.
We receive regular updates on this, so we'll scrutinise through that.
And you'll bring us updates to the board as relevant.
And yes, got it.
Thank you. We'll move on then. I know Sue Stansfield, welcome as always. So we'll do the maternity update report. I'll do it this way. I'll ask the chief nurse to introduce it. Then I'll check with the chair of quality, Sue, and then we'll come to you for the actual report.
Okay, over to Sue Stansfield, our director of midwifery, to take on our maternity report.
Okay, but before you speak, Sue, I'll ask our chair of quality, anything to escalate from the maternity report, please?
I think the key thing we wanted to escalate is, and Sue does pick this up in the report, is there's a particular metric around consultants must attend in all circumstances. And we had 4 out of 7 occasions where consultants had attended in the previous period. So we discussed that at Quality Assurance Committee, and Sue confirmed that they're looking into the specific circumstances around those to ensure. Normally we've been fully compliant, we have 7 out of 7, 10 out of 10, but this time it was 4 out of 7. So that's something that was being picked up, and we'll come back through to quality.
Thank you. Hey, Sue, over to you, please.
Thank you, Chair. I'll take the report as read as usual. It's a regular maternity update to advise, alert, assure and update board on maternity. As Chair of Quality Committee has just described, particular concern around consultant must attend in being at 58%, and we're looking into those occurrences and what happened. As Sarah's just described, there's usually full compliance with this. We're just looking into, actually, is this because a consultant was called, didn't arrive in time, or whether they were dealing with another emergency and there was 2 things happening simultaneously and they weren't able to attend. So that report will go back through Quality Assurance Committee next month. Just 2 things I wanted to point out as part of the report for assurance. 1, the Maternity and Neonatal Voice Partnership Work Plan was signed off by the local Maternity and Neonatal System Board in July. And again, that's been discussed in detail at Quality Assurance Committee. So we've got a fully funded work plan for our maternity and neonatal voice partnerships, which does include this time reaching out to hard to reach groups and making sure that we've got consistently voices heard through our maternity service. The other thing I just wanted to point out for assurance is the maternity self-assessment tool 6 monthly update is included as part of this report and is included as part of Appendix 3, and you'll be able to show improvement there from December 23 to date in 2024. So we continue to make steady improvements against the maternity self-assessment tool. I'm happy to take any questions.
Thank you. Okay, Aaron, please.
Yeah, thanks for the update, Sue. It's just in respect of the consultant not attending, kind of those 3 out of the 7. Has there anything been highlighted in those cases in terms of harms or incidents?
No, we've not picked that up. So we have had a look at that already. It's one of the first things we did, and there's been nothing highlighted from that perspective. So there will have been a registrar, obviously, and a senior registrar in attendance at any of those instances. But we're just having to have a look at what those delays were.
That's great, thank you.
Can I request, when it comes to quality, Sarah, that you provide a report to the board through your quality minutes
Yes.
of what the reasons were, so we can close the loop on that. And then, be preventative steps if required. Okay, thank you for that. I'll look round, speaks for itself. Sue, you've given us the regular update. Quality's overseen it. Yeah. Okay, thank you. Sue, thank you.
Thank you,
We'll
sir.
see you again.
Thank you.
Okay, we'll move on to the performance and resource aspects of the board minutes, for the board agenda, sorry. So we're on 57.1, the integrated performance dashboard. Deputy Chief Exec, to lead us through this, please. This is for assurance, this paper.
Thank you, Chair. So my introductory remarks are set out within the executive summary, so that I won't rehearse those here. I propose we go straight into the executive director updates by section of the main report. And as usual, I would invite the Chief Nurse to start.
Thank you, Chris. Thank you, Chair. So looking at our, quality and safety performance, we'll start with the patient safety incidents, which is now being overseen through our new PSAFE framework. We have got 2 PSAFE which have been assigned for investigation under the new framework. We have an issue around PSAFE in terms of the numbers we have, because we've got 18 that have been commissioned and 2 that have been completed, simply because of our staffing to sort of meet the PSAFE requirements. This is going through the operational business case process, so I don't need to go into detail with that. But I just needed to highlight for board to sort of say around the PSAFE methodology, the issue we have at the moment is the PSAFE investigators, which we need to sort of look at, and we will look through that through our EDG. In terms of complaints, there are no complaints that are now exceeding over 6 months or over 5 months. So we are on trajectory. Most of our complaints remain in the medicine care group, where we have about 90, which are sort of outstanding, but they are all being progressed. But the focus in terms of our complaints, one of the measures we have now is the quality of the complaint response. And we're looking at the number of the revisits. Why are these being revisited? So the focus on the complaints now is on the quality of the complaints, as we are sort of dealing. We don't have the numbers that we had when I started, where we had about over 200 complaints. So we are going the right way, if that makes sense. And we just have to continuously improve the quality of our responses and engage with the families and patients and carers, which links into the PSAFE as well, which is the first thing. Our falls, we continue to see an improvement. We've had 8 consecutive months where we've seen a continuous improvement. So we've had 87 slips, trips and falls. Just 1 resulted in moderate harm. We're not taking off our feet off the pedal simply because we continuously improve. So we just have to continue sticking to effective risk assessments and making sure our patients are not lying in bed throughout their care with us. We try and mobilize where we can so that they're not deconditioned. So that's one of those things that we continuously improve. Pressure ulcers category 2s remain a bit stubborn. We've had 18, but we did a deep dive, which I brought to board the last board to sort of show that we're not causing any harm to any of those category 2s, and our focus should be on the 3s and the 4s. So the category 3s, we've had 4. Well, it's because we've had new guidance that unstageable pressure ulcers should be counted as category 3, if that makes sense. So as a board, I think we should be assured that we haven't got any category 4s at the moment, because when we reach to that, we go into safeguarding sort of way. So we continue to monitor and support staff and educate. Family and friends test, I can assure board now, we are exceeding the target for this. We have really increased. We are now sitting at 94.48%, and ED is also increasing. They're sitting at 85.89% against the target of 85%. So that has seen an improvement in terms of how we are receiving feedback from our patients through, like Emma mentioned, we've increased our volunteers and we are increasing staff to go and talk to patients and actually hear feedback. Mixed sex accommodation breaches remains an issue. We've had 29 simply because we discussed this at performance. We haven't got many side rooms, but there is now a QI, quality improvement piece of work that's being led by the newly appointed critical care matron to actually see how we can unlock that and reduce the number of mixed sex accommodation breaches. Infection and prevention control, we have reduced our C. diff cases. We've only seen 4 cases of C. diff which were healthcare associated. The main issue at the moment, but we are monitoring it, is the incidence around our blood-borne sort of infections, which remain at 15, lower than last board meeting, which was 18. So we continue to promote training, PPE and everything to reduce infection within our areas. I will hand over to the medical director for VP and mortality. Thank you.
Thanks. If I take mortality first, actually there's, I've just noted that the data says February and March 24 on the graphs. I think it has been updated since then, so I'll make sure that's corrected. However, our overall mortality for the trust remains lower than peers and lower than all other trusts. And the 2 alerting groups are the same 2 that have alerted for a little while. The conduction disorders, there's work going on. The issue is not around coding being incorrect, but that then we had a number of patients who were not suitable for treatment. So the coding was correct, the patient didn't have the treatment, and therefore we had an obvious higher number of deaths. But that all of those cases are validated and worked through by the teams. And then the work goes on with fracture necrophy, which is reporting through quality committee directly, I think quarterly or thereabouts, isn't it, now. And there are a number of small pieces of work within that are being undertaken. On case review, quite a lot of the cases probably were elderly frail people who were actually fit to undergo surgery. So similar to the cardiology, what we weren't good at was identifying where we were in, harking back to the first conversation this morning, where someone was dying and therefore was not for treatment rather than expected to have treatment and recover. So there's a lot of work going on around that. With regard to VTE, we know we've never been where we wanted to be, and we are some project management support in to support that and really take apart the data again. It looks much worse. We expected it to look much worse, and we had long discussions around it at quality committee. There has been a change in some of the data definitions around it, which we are working through to make sure that our denominator of people we should look at is correct. And the first workshop was held last week around that assessment, which was well attended by the care groups, and I think I'm told was really useful. However, Carrie asked me a question last time and I got the data back around, do we know cases of hospital acquired thromboembolism? Did they have their assessment done? So it's not an easy data trawl, and we've only really been able to get this from January of this year. Prior to that, what the data was provided was all of those people who'd undergone either a CT pulmonary angiogram to look for a pulmonary embolus, or had ultrasounds of the legs to look for DVTs. And so the team would get about 250 plus reports a month that we'll trawl through to then try and marry up. We've now done things a little bit better, and we're having a report of all of those that are positively identified. But the data from January to July, which is the 6-month period we've been able to get, there were 74 cases of VTE identified. Of those, a third, 25, met the hospital-acquired thromboembolism criteria. So we don't count it if it's within the first 24 hours of somebody arriving, because they probably came in with it. Those 25 patients all had a VTE risk assessment, and that was done within 14 hours of admission, so they all met that criteria. 8 of the 25 didn't then go on to have pharmacological prophylaxis. 7 of them, that was because we've got clearly documented contraindications, and only 1 person we couldn't find a contraindication to it. They did have stockings, but it appears they didn't have low molecular weight heparin. So 1 of those 25 cases we identified effectively a lapse in care. And so we have some assurance that whilst our figures look awful, those that have gone on to have a hospital-acquired thromboembolism have actually had appropriate assessments done. And like I say, 1 case didn't have the appropriate treatment. So Carrie, I hope that answers your question from last time.
Yeah, thank you. So out of the 74 cases, 25,
yeah,
you said there,
yeah. Let's go to the summary if you like.
Yeah, please, thank you.
Okay. Deputy Chief Executive, moving on.
People section next, Chair, Chief People Officer.
Thank you. So just a couple of points really to pull out. So one around the vacancy position. I referred last time to the fact that this is in special cause variation with cause for concern, but there is actually no reason for escalation associated with this. It's linked to the approval of business cases that have a financial benefit that bring services back in-house or convert from premium rate expenditure into substantive, and there is no noticeable variation and increase in the turnover, which would be the kind of balancing for that. We also have been managing some of the nursing vacancies because of the students that we know are going to qualify this month, to make sure that we're in a position to be able to offer as many of those employment as we can. There have been some delays to the vacancy the process of filling vacancies, I suppose, really through the vacancy control processes that we've put into place. And just really, I think, important for the board to be aware that we do continue to use our trust agreed business and safety critical criteria when we're assessing any vacancies for approval in our vacancy control panel. There is a potential for this position to change slightly as we talk through some of the kind of consequences from the system-wide finance financial work that's happened. We might see some changes in this in future months, but we'll just keep an eye on what that looks like. Important here, I think that we recognise that from a quality and safety perspective, that the fill rates for all those shifts remain at target level, and the agency reduction programmes that we've got in place are working. We're progressing as planned, and you can see from the agency section in the finance report that we're currently under the 3.2%, which is the nationally mandated ceiling of agency payable expenditure. The only other point I wanted to pull out was around appraisal. So again, we can see that there was a drop in appraisal compliance that started in April. That is as we would have expected it to be, because we transitioned from a kind of time limited kind of cascaded appraisal year to appraisals being spread throughout the course of the year, and objective being cascaded through based on the start of the new financial year. So we did expect that to happen, but there is a recognition that there needs to be increased focus on making sure that those appraisals are all booked in, and that's managed through the performance reviews with the care groups. And we can see that we've got all areas are increasing the level of bookings of their scheduled appraisals, some in the region of 10% in months. So we know that the processes are working. It's just a case of keeping an eye on that and making sure that we're monitoring through the performance reviews.
Finance section next, Chair. So the trust reported a year-to-date deficit of 16.3 million to the end of month 4, so that's to the end of July, and that's £3 million higher than we set out in our financial plan. Our plan explicitly did not make provision for the cost of industrial action, which occurred in the first quarter of the financial year, and that accounts for £450,000 of that adverse position. The overall position is made up of a combination of overspends, some positive performance resulting in underspending, but also slippage against the trust's cost improvement plan requirements. The report flags in particular financial challenges across the medicine and surgery care groups. Material to this has been high variable pay and agency costs and the delivery of care group financial recovery plans in the first quarter. Whilst £3.5 million of cost improvements and savings were delivered up to the end of month 4, the target's £2.5 million higher than that, and it increases throughout the remainder of the year. So, as the board's aware, the Lancashire and South Cumbria Integrated Care System is one of the 9 systems nationally identified for national investigation and intervention regime. Due to the scale of financial challenge and the levels of risk contained within the financial plans, all NHS providers and the Integrated Care Board are fully engaged in this work, and the trust grip and control processes and our financial performance improvement planning and delivery arrangements have been self-assessed and subject to scrutiny by representatives of NHS England, PA Consulting and the Integrated Care Board. So I'll report to the board on that work in more detail later today, but specifically in respect to the financial challenges identified in the month 4 finance report, we've done a number of things. Firstly, we've built on our established pay control processes to continue to drive high cost agency usage further below the NHSE identified ceiling and enhance how we manage our variable pay costs, which are material to our financial performance at this stage. We've implemented further enhancements to our overall financial control environment, building on the progress that we've made through the Sustainable Financial Improvement Plan, both those identified through our own regular review arrangements, which have been in place for some time, and additional feedback received through the investigation and intervention reviews. We've also further enhanced our financial improvement infrastructure and capacity in addition to the arrangements which successfully exceeded our recurrent savings target last year. The headlines of this is that we now have in place dedicated senior financial leadership to provide continuous support, review and challenge on a daily basis. Specific commitment from the entire executive team, which results in us dedicating support and rapid review alongside the care groups to ensure that we address the blockages or issues which have impacted on the pace of delivery of the opportunities that have been identified within our plans, and establishment of the Financial Sustainability Delivery Group, which of course is chaired by Tony as the non-exec lead on that, and focused on ensuring that we are addressing the factors which would limit our ability to manage to plan and ensure our infrastructure and support arrangements actively promote financial sustainability and the effective use of resources in line with our trust objectives. There's a whole lot of detail behind that. There's a lot of granular action and activity, which of course I will expand on later today, Chair. Thank you. And we've finished this section with the Chief Operating Officer.
Thank you. Brief in this section, I think the summary covers this pretty comprehensively. So for urgent care, you see we've had a good summer. You see 2 data points above the 78% target for the first time since the COVID pandemic, and top quartile performance as a trust, with RLI being at 63.5%, which is by and large what I'd expect and want it to be given the conditions that it's in. So clearly much room for improvement, but it's come from the kind of mid-50s to the mid-60s, and sustaining that over seasonal winter will give us our best opportunity of achieving the 78% trust-wide national target. For ambulance handovers, again, good progress, not meeting criteria to reside. You'd see in the graph on page 219 a trend towards reduction in NMC2R, and it certainly has come from that kind of chronic number of around 150 to nearer 100. It's 119 today, So some of the moves that are being made are impacting on NMC2R, and as we've described in many other fora, there is a lot in plan. We had a comprehensive discussion at the last F&P around the plan to address NMC2R that we've had signed off through the Improvement and Assurance Group led by the Integrated Care Board. Something I think we probably don't celebrate enough as a board is the three, we are the envy of many in achieving our 3 cancer targets. So those 3 national cancer targets, we've got sustained delivery of those cancer targets, which is not by accident and significant amounts of work by the teams. And sustained certainly in the combined 28-day, 62-day, but having now achieved 31, and albeit in common cause variation, then I think there's much to celebrate there, with, as ever, much more to do, as reducing improving that performance further. Diagnostics, the text on page 223 alludes to some kind of staffing and equipment issues that kind of stressed the diagnostic system, but nonetheless, the performance remains sustainably below the 5% target, and we are 6th of 114 trusts nationally, so performance is good in diagnostics, albeit there's some stuff for us to do in terms of resilience, particularly as we go into seasonal winter. Referral to treatment time, you see there we in the top quartile for the 92% target, however significantly short of the target. Our trick to achieving that, of course, will be in reducing our waiting list size, and you see on page 227 the sustained and ahead of our own target waiting list size, and so it is pleasing to see that continue to drop, and that will ultimately impact on referral to treatment time. It is impacting on our long waiting performance. We have and will escalate 2 things in this space in the last, and so not in this reporting cycle in today's board papers, but in the both subcommittees. The risk in orthodontics for access in the round, particularly for long waiting access, is escalating, and it maybe we take some pretty stark measures for orthodontics, and we're engaging with the ICB around that as we speak, due to staffing resilience. And secondly, the impact of our medical rate card for pay for SAS and consultant doctors is now impacting on elective access. So we're seeing activity diminish and the take up of additional activity sessions diminish as a consequence of the rate card, which was largely expected. And again, it's a balance of access, safety, quality, and best use of our resources. Finally, you see the downward trend continue in our missed appointment performance, although the last 2 data points coming out of special record improvement, and we've got some recovery actions around that. We'll report back through F&P. So in the round, it's positive urgent care performance, positive trend in any and not meeting criteria to reside, some excellent progress in cancer and elective access, some work to do in diagnostics and missed appointments. And the final one, if I may, the reporting period in the papers for stroke validated data is a A for SNAP for Furness and RLI. This week's unvalidated data we've received would tell us that in Q1 that we are a B for both sites. It's a very fine margin, so you'll see in the key on page 231 that over 80 scores an A. So in this reporting cycle, we're over an A. We were at, I think, 81, 82 points for the sites, and the B in this unvalidated reporting period, I think, was 78, 79. So I think if that was an SPC, it'd be normal variation, and that will come through in the papers in subsequent boards. Thank you.
That's excellent. Thank you, Chair. Okay, thank you. Just before I take questions, colleagues, just so that we've got clear assurance procedures. The report, Jane, that you verbally updated us on thromboembolism, I know outside of the meeting you'll send the data to Carrie, it'd be useful as well if you sent it to the COSEC for inclusion in the minutes. And if the COSEC in turn could send it to the quality committee, so you've got the information there as well, please. Okay, questions then, colleagues, to our exec colleagues on their various reports? Anybody wish to raise anything? Tony? Tony?
Yeah, a request really, I was wondering, and we've not had a chance to talk about this, Karen, whether the People's Committee could look at appraisal. Because that's been, it's mentioned in the CQC and it's been a recurring theme, I think, for quite a while, that we don't seem to be able to sustain or get to the ideal position. So I'm asking whether that's something we could look into, if that's the right mechanism.
I think so.
Just let me just make sure. Just so we don't get operational. Do you mean the mandatory training or do you mean the compliance numbers?
The compliance numbers.
Compliance,
Yeah. Absolutely, that is a feature that's reported and considered of people, but we can, in light of the conversation today, give that some focused attention through that committee. Yes.
Great, thank you, Chair. Thank you. Sakthi, please.
Thank you, Chair. I mean, firstly, I mean, I get to see a number of performance dashboards across the system, and this one really needs to be commended. The way that we use data and we discuss performance, and particularly common cause, special cause. And my question is really for Scott. In the operational performance, it's great to hear the cancer targets being achieved as a national exemplar. And I was just triangulating that with the list of metrics for cancer. I think there are 11 in the glossary. Only 3 are presented. So I was just wondering, is that pattern being seen across the other metrics for cancer as well? For example, screening and so on.
Yeah, thanks, Zach. That's a great spot as ever. You're right. The 3 more kind of nationally reportable ones are the ones we bring to board. But the point you make does stimulate a thought that I don't think even at the performance committee we do enough justice to the other 8. So I'll take that into the next performance committee through Amin, and we'll make sure that those are cited and reported to board in the same way.
Thanks, Sakthi. Eagle-eyed as always. Thank you. Sarah, please.
Thanks. Actually, it wasn't a question. I just wanted to provide a bit of assurance and update related to a couple of the things that have come through from
Outside of the next item.
We
should be doing the quality assurance update.
Well, it was related to VTE, and so I thought it was relevant to do it here. So I think just to follow up on Jane's point, we have had significant discussions around this. We had a full update report to the committee in July. So we were cited on the fact the data was going to deteriorate, and I'd picked that up in the 3A's report. I think there are a couple of things I did want to highlight. So the first is responding to a question I think Aaron asked in the last board meeting about how are we using quality improvement as part of this. And so Helen, isn't it, who's leading that work, was at Quality Assurance Committee and talked us through. So there's a full quality improvement project attached to this. That's identified, that's looking at barriers to compliance, and it's identified both data and pathway improvements that need to happen. And we've got 2 key dates that we're now monitoring. So the first is that by the 31st of October, we're expecting the data to be correct. And notwithstanding, we've sort of had now some potential additional things around data definition. We're still looking for 31st of October for that data to be correct, as well as sort of the audit pathway also being agreed by them. And then with the pathway improvements and engagement that will happen through the QI work, the trajectory is to reach the 95% target compliance by the 31st of January. So those are the 2 dates in particular that we are looking at from a quality assurance point of view. So we'll be receiving an update in October, which obviously won't be 31st of October, but it will update us on progress then. So that was the first one. I just thought it was really important to draw that through. And the other was around fractured neck of femur. which, as Jane highlighted, there is a piece of work around. Again, I think there's some quality improvement team support attached to that, and really good engagement from the surgery and care group actually in terms of talking about this, around the clinical engagement that's needed. And absolutely, they talked about that point around we may still need to undertake an operation for fracture leg femur, but it doesn't actually necessarily mean that the outcome will be different. It might just be more of a palliative approach. So again, there's some focus on making sure the data that's captured is correct so that we can see that through. And we'll be receiving an update on that in the September meeting. So those were just the two things I felt merited a little bit more assurance in terms of the discussions we had.
Thank you, Sarah. Thank you. I'm going to keep taking questions, so take Mike, then yourself, Karen. Mike.
Scott, thanks for that. Just on the rate card of the drop of inactivity because of the more stringent application of the rate card, just some assurance around that data's coming in quite quickly and that it's been fed to Chris in his forecasting.
So it's been in place for around 6 to 8 weeks. We are seeing it, so our teams are seeing it. They're telling us that they're not deploying activity and therefore seeing activity change, and they're now counting that. So that we'll count that and reflect that against the activity we expect to do in terms of performance, and I guess count the money that we didn't spend. So it will reflect both in the performance data and the financial data.
I had a question, but also just to respond to that point, and it comes later in the 3A's report that Amin, as chair of finance and performance, myself as chair of people, and with Scott's support, have agreed that we'll triangulate that very point between the two committees, the people elements and the performance elements of the application of the rate card, and keep that triangulating under some close scrutiny.
We've been talking specifically about that issue in the report that expected to feature in the next.
And you had a
And
question.
I had a question, and my question really related back to vacancy rates and how we understand in the narrative and the Ali's report, some of that is anticipated and really results from the application of some of our pay control processes that are really robust and are working really well. But I just wonder whether we will continue to report the explanation for that as part of a narrative, or whether we do need some recalibration to reflect that.
So I think I was off when this was prepared, so we will pick up a little bit more properly appropriately in the narrative going forward. What I would say is that we probably will pick some of this up as part of the discussion around the finance element as we move into the session in part 2 today, and that will probably address some of the questions around recalibration.
Thank you.
And just before I bring Aaron in, Scott, just to give you the heads up, I know later on we'll be doing the winter planning. Just one of the issues I'll probably raise is not meeting criteria to decide coming down good, 100 patients still in, not good when we go into the winter planning, the impact of that. So I'll bring it then rather than here. And a quick one for you on diagnostics and one other. Is there a timescale you've got in your head or the team has about how we can reverse that decline and start building it up again?
So certainly in barium, which is the biggest one, I'm hoping in this calendar month in September that'll be back on track and we'll have caught up. And the resilience things around staffing, I would hope, if not in this month, certainly by October, we'll be back to the resilience that we've always seen in diagnostics.
So in the next board report, we should see.
And the next board report will describe August, so you might see that facility, but the one after, yeah.
All right. Okay, thank you. Thank you. Chief Exec.
Thanks, Chair. Just a couple of points. Sarah's helpfully answered my questions around trajectories. Thank you very much. Interesting though, the time period that we've had where VT has been an issue, and we get the CQI, and it looks like I'll be chuffed if this happens, but between November, December, and January, and anticipated 95% achievement, would be great to see what it is in that learning from applying an improvement methodology that means we've got there. So look forward to seeing how that's going. One of the questions I've got is around the PISA business case, Tabitha, just making sure. I know we've got some alternative arrangements now with some temporary resource, just a timescale when we're expecting to see the case come back for consideration for capacity.
Okay, so it went to the finance group IP, yeah, yesterday. So it will be coming to EGG for us to sort of have a look.
That's next week.
Next week,
Okay.
yeah.
Thank you very much. And then the last one is it's a thank you for the team in the ED at RLI chair. I think we talk about special cause improvement, etc. The SPC, but to have a 10 percentage point improvement from where they were after some really focused challenge. Again, lots to go at, but I think that's testament to a bit of tenacity and a bit of grip and control and a bit of rigour within particularly the clinical teams within ED. So it's right to celebrate, I think, the triumvirate there that they've responded. Look forward to seeing that continue. The point I was going to make, Chair, is 2 or 3 times, even in this IPR update, we've heard some delay in PISA because of a business case for capacity. We've heard potential elective impact because of rate card discussions on the finances. We will increasingly as a board see some areas of risk or deteriorations because we're having to apply increased financial discipline, rightly, because we're tens of millions of pounds away from our budget. So I just want to flag for the assurance committees when we're triangulating, particularly with quality impact assessments and areas of deterioration, where we believe it's because we're taking action under the I&I and the finances, we need to track that and make sure we're triangulating it at board, Chair, so we can take some considered views around risk and just a point to make.
And just to comment on that, we have agreed we're going to receive a quarterly report on the quality impact assessments that are being undertaken as part of those processes so that we can scrutinise that.
Go through that action, Chair.
And just to add on what the chief exec says, the objective is to continuously enhance care. So the report, Scott, particularly yours and others that we've had, are showing improvement, but then we move into incremental improvements. You get 10%, brilliant. I think that's really good, but then we need that 1%, then 0.5%. We just have to keep that pressure on, really. And the second bit is, Chris is well aware of the financial pressures of the trust. But the goal is to have a good financial approach alongside the equal priority for high quality patient care. The other doesn't have priority over one, so it's a good point to make there about a close eye on that. And taking your point about RLI, we need feedback through the executive group, the board's thanks and appreciation. Any other questions then on the dashboard, the updates? No, okay. We move on to 7:57, 2 minutes of the 3A report. Usual routine, colleagues, if that's okay. Escalate what you think is relevant to the board from your various committees. We'll start with audit. Tony?
Yeah, thank you, Chair. So there are 3 lots of minutes and 1 3A's report. Just 3 items to highlight. One we've just touched upon, the quality impact assessments, the internal audit reviews. At that point, gave limited assurance in regards to the methodology and process. However, at the last meeting, the chief nurse gave us a really strong presentation in terms of assurance around how the new process would improve. And as you've just heard, we've ensured that the quality committee kind of had the responsibility to check the quality of those assessments going forward. So that was one item. Second item is a small matter, but it's a good news item in the sense that we received reports on issues in regards to kind of white words there, losses, receivables and payables, which is basically where the money's going in terms of some of the losses. There was a bit of a trend around pharmacy in a nutshell, not a significant number, but the trend compared with last year in the improved report showed that more was lost in 1 month or 1 period than the previous year. So they've gone away to look at that and give us assurance. And then the last item just to raise was, again, the committee considered an update from the Emergency Plan Resilience Group and was alerted to the fact that several local security policies and local emergency plans were beyond their review date. So again, we've asked for those to be reviewed and assurance provided to the board at next committee so that we can kind of sign that off. And the the rest of it is in the notes for me.
Okay, thank you. Any questions for audit? No. Okay, we'll move on to the People Committee. Karen, provide us an update. You're also going to tell us about the North West BAME Assembly.
Yes, thank you, Mike. So the a number of points within or a number of elements of the 3A's report actually appear later on the agenda today, including the people strategy, which the committee reviewed and were very supportive of, recommended to the board. That will be coming later. We've already touched on the application of the medical workforce, the new rate card, and how that's going to continue to be monitored. Just wanted to draw the board's attention to a committee focus on assurance reporting on DBS checking. That's something we're focusing on as a committee, and that work's underway with a strong focus on best practice and particularly enabling effective data reporting, so that the team are really looking to produce a much more systematic approach to being able to give us that assurance. And the committee will take a further, more detailed report and any improvement recommendations in October. So we'll bring that back to the board. The summary inclusion report that the committee considered with no particular escalations to the board, that appears later in the agenda. Just particularly wanted to highlight a report following a debrief on the Trust incident response to the recent period of civil unrest and acts of racism. It was just notable that there were a number of programmes of work and actions that were either already in place or were able to be implemented very rapidly in response to that situation. So there was some significant reassurance there that those actions were able to be implemented effectively. We also considered an appraisal revalidation and medical governance report that is coming to the committee later, and the committee supported that submission. And then with regard to the Northwest Bronze Anti-Racist Framework accreditation award, actions are all on track, and we're anticipating being ready to submit the application in March 2025. And again, the committee will take an update and will review that submission in its February meeting.
I'll take that as a proposal to the board, if that's all right, Karen. So I'll propose to the board that we approve the People Committee reading the submission for the Bronze Award and taking it through the People Committee under their remit.
So whilst I would agree with that for the majority of the criteria, there are criteria that are associated with patient access and patient engagement and community engagement. So I'm just conscious that People Committee probably isn't the group for single sign off of those items.
Okay, which would be then?
That would be quality.
So how about then we propose it goes through the People Committee for scrutiny, comes over to quality and sign.
Yeah, and we can schedule that time wise, because I think those committees are both on the same day. But we could coordinate that. Thanks, Ali.
Let's summarise for the minutes then. Thanks for that, Ali. So we're asking to approve that the People Committee actually review the report before it goes in and then submits it to the Quality Committee for sign up, so that we can take on those extraneous issues.
Yes.
Okay, approved. Thanks, Karen. Any questions then to the People Committee? No. Finance and Performance, the Minna sent his apologies. Tony, could you report, please?
Yes, so there's two chairs' reports and a series of committee notes. I'll just reflect on the August one, if that's okay. And again, just a few things to highlight. We've heard Chris explain the current position regarding the finances. Those were reflected in the discussion at the meeting. I think it's fair to say through the Finance Sustainable Delivery Group and the committee, which that group reports into, there is significant effort being made to influence and shape the required expectations, particularly because of the slippage in terms of the cost improvement programme, which has impacted on the overall deficit position. But thanks to colleagues, all colleagues, because it's significant work that's been undertaken, and clinical engagement came up as a key theme in terms of making sure that delivery, in terms of quality outcomes as well as physical outcomes is maintained. We've had a long discussion about medical rate cards, so I won't repeat that, only to say that the mitigations outlined by Karen were agreed in terms of the liaison between people and finance, and also the reporting going forward. Third item to raise was we had a significant conversation about the pathology service. There was recommended refinement to the model going forward. I think further work is being requested by the committee with the productivity, best value and regional fit in terms of both clinical outcomes as well as the financial strain that the system's under. So further work's being done on that, and a report will be received at a later point. And the final point is to note, as highlighted, the urgent care and progress in cancer diagnostic standards, the positive progress being made there, that was highlighted in the committee and was noted. Thank you, Chair.
Questions for finance?
Mayor, just an update on the pathology point. That was very current. We had a long discussion with the executive directors meeting yesterday. Our investment priorities group reviewed the revised proposal, and I've also now had an assurance around the procurement aspects. So I'm satisfied those issues would be resolved. We would be now recommending that we conclude that, and I'll bring it back to you.
Great. You'll take it back to finance? Yes.
Yeah.
Great.
Thank you, Chair.
Okay, Chris, thank you. Any further questions? Finance? No. Quality then, please, Sarah.
Thank you. So again, we've got 2 sets of minutes and 2 reports. Just to flag, we have had some challenges with chorusy for the committee over recent months. We've sort of identified that as being partly sort of administrative process around processing of apologies and how they're registered. So we're working with the company secretary's office to make sure that we're very clear about attendance and chorusy. And we had really strong attendance and chorusy at the last meeting, and I think actually as a consequence had a more robust discussion as well. So you know, all the reasons why it's really, as well as strong exec input as well. In terms of things to alert, I think this has been previously mentioned, but to note formally that the trust received a prevention of future deaths notice, and that's being reviewed, and a patient safety incident investigation had already been triggered, so that was reassuring that obviously we knew about this, and the response we were assured that the response would be provided to the coroner within the appropriate timescale, and of course we'll also be reviewing just to ensure any lessons learned come through from that. We've touched already on some of the key quality metrics, so fracture neck of fever and VTE. So the other points that I wanted to mention, a point of assurance, Tabitha talked about the fundamentals of care, the fact we've had sustained improvement in terms of reduction in falls. On pressure ulcers, we were also assured that actually for category 1 and 2 pressure ulcers, there's been analysis around that and actually found that the kind of improvement that would be needed is less than 1% now on that, which means focus can be very firmly on category 3 pressure ulcers, with a quality improvement project attached to that, and the ICB is also supportive of that approach. So I think that's actually quite assuring in terms of the progress we're making. We received the annual risk management group report, and we were assured that an MIAA internal audit gave substantial assurance for our risk management approach. And I think it's important to note that in the context that 3 years ago we had limited assurance on our risk management approach. So I think that demonstrates real improvement over time, and I think it's important to note that. Other key points to mention, we've seen an increase in the surgical site infection rates at RLI, Royal Lancaster predominantly related to I think trauma and orthopedics and lack of ring fence beds, which is a known issue. It is being managed, but a working group has been established, and cases are being reviewed with an action plan being put in place. So I think it's important that we know that. Again, we had quite a conversation about that at quality committee, which others might want to come in. We reviewed the BAF, the Board Assurance Framework, and Quality Assurance Committee is recommending the inclusion of a risk which relates to the potential impact of the GP collective action on acute services. So we've had a standing action around internal industrial action, but actually we felt it was important to consider that. And in our own review of our quality risk register, we're maintaining focus on those risks which will remain out of tolerance even once mitigations and actions have been taken, and also the risks which just simply haven't shifted over a year. And we also just noted that real sort of triangulation and consideration between financial constraints in terms of investing in new equipment and the risks that might carry, but also just making sure there's mitigations. Just the final point, we approved the terms of reference for a health equity committee, so really good that that is now been approved and the first meeting has taken place. So we'll look forward to starting to see the plans for that and the improvement and the strategy. Sorry, a bit long.
Good. Questions, quality?
Just one clarification, if I may. So Sarah's had a really good conversation about surgical site infection generally, and then particularly in elective arthroplasty. And Jane talked to the National Registry data, and we did, just to help Nicola with the minutes, we did talk about surgical site infection being higher than the benchmarked average, and we did talk about the absence of ring fence beds. What we didn't talk about and didn't hear was a direct correlation between the two that's evidenced. So just to help with the minutes, we've not seen a kind of causation between no ring fence beds and increased SSI, but we do not have ring fence beds, and part of our estate plan is to create ring fence beds and do arthroplasty in a different way across the trust that would address that issue. And I think if there had been a very clear causation between the two, we'd be taking emergency action, and at this point we've not received that expert advice.
We take that as a clarification anyway.
Is that fair?
Yeah, that's right. Thank you.
Thank you. Sarah, you okay?
Yeah, yeah.
Any questions, quality? Happy to accept the report. Yeah, thank you. The next one, new hospitals programmes. There's the minutes of the 17th of April, 25th of July, and also an advisory. You've got the minutes. There's only one thing to escalate, that's advisory around coming to the board at some point for permission for the chair and the chief exec to sign any relevant documents. But like the COSEC, is anything to update us on that?
Yeah, just to give an update as to where that is in terms of kind of process and approvals. Every trust that's involved with the new hospitals programme will be required to enter into a formal NHP agreement. There's a kind of a national review that's been done on a consortia basis through the programme directors for new hospitals programmes. We briefed the committee on that. We've been encouraged to seek independent advice on that, which we've commissioned jointly with colleagues from Lancashire Hospital. Tapsticks undertaking that work. Once we receive that work, we'll then be in a position where we can begin to finalise the agreement. We don't have a timetable yet for when that will be. We anticipate that it will be fairly imminently, and that will be then subject to either a further report to the committee or, as has been proposed here, an authority for the chair and chief executive to sign.
This is just an advisory. Any questions on the NHP? And then Transformation and Improvement Board, Tony again, please.
Yeah, thank you, Chair. So early days, in short at the minute, we have now, as in the report, a product which is the kind of roadmap for service transformation improvement. That resulted in a well-led event by Scott for the board in terms of articulating what the kind of key pieces are and the interdependencies. Further work will be led on that in regards to priorities and time scales. So that's the first element from the report. The second element is around diagnostics, obviously, and so what's the impact of this? So that work is being worked up as we speak, as a consequence of recent discussions as in the report. And the final point is just to say a future element will be about financial investment. A lot of the work will be done for efficiencies and redesign and modelling, working with what you have. But we need to be minded about future investment in regards to modernisation improvements. That's it, Chair.
Thank you. Aaron, you want to come in on that?
It's just an ask, I think, from me for Tim, which is, as a system, we're going to be asked to reprioritise where we believe the biggest impact's going to be for transformation improvement work, particularly in light of the I&I process and this year's financial plan. So whilst I appreciate we've mobilised quite a few transformation improvement programmes, I think it would be wise to do a quick review to make sure that if we could deploy resources in a different way in those programmes to better effect over the next 6 months, there should be a consideration of a risk-based view of that. So I'd ask the TIP just to oversee that and see if there's something else we might want to do in those programmes over the next 6 months.
Yeah, absolutely right. I think that is something we're moving into now, because there are many spinning plates, but it's which lens you're looking at and what risks you're prepared to take.
So we take that as a proposal to the board, Chief Exec.
Yeah.
Chair, you're happy to
Yeah,
take
we'll
that
have
on?
that.
Yeah, rest of the colleagues, yeah. Okay, thank you.
Thank you.
Any other questions for the TIP, Transformation Improvement Board? No? Happy to accept the report. Tony, thank you. Colleagues, we'll move on then. We'll have a short break after this item. Item 58, winter preparedness. It's already gone through finance and performance. I'll just ask, I know the Chair of Finance on leave at the moment. Tony, it's gone through there. Anything to escalate, any exceptions? Are you happy for it to come and recommend it?
No, happy. We had a lengthy discussion about it and we're happy to support it.
Thank you. Go to the coup.
So yeah, on that basis, I won't clearly talk through it. A couple of bits to pull out. The table on page 360 shows things that are going on across the system, and it is important to note the benefit we have and will receive from the acute respiratory hubs, the intermediate care beds in South Cumbria in particular, and the second phase of the Morecambe Bay respiratory network. So that investment is welcome. There are some risks in the respiratory stuff around recruitment, but nonetheless that's welcome. So the paper recommends paper digested two options. An option to deploy additionality because of the known of additional winter pressure in January and February, or in January, February, March. Pragmatically, given where we are, we've taken, and not without risk, we've said that we would go for the first option, which is an 8-week period of additionality. We are worried about March. March was difficult last year. And so I guess we will be agile in terms of how we assess that to Tabitha and Jane's good offices once we get into March, or certainly as we end February. The tables on page 362 on 362 describes the nature of the additionality, so some additional beds in RLI and in Furness, some additional senior medical in Reach, and some additional home care and therapy. You may look at the paper and wonder why it's slightly more expensive this year in terms of staffing that additionality. The answer is, at this time last year, we had a pipe incoming international nursing colleagues. That's not the case this year, so that offset isn't available to us. And as ever, the reason the paper is expressly authored by Jane, Chris, Tabitha and I is because in terms of quality, safety, access and financial risk, we're triangulated, and you see in paragraphs 14 and 15 saying that we are seeking to employ additionality, and there is a risk in this, but we believe this is the best calibrated risk in that kind of quality, safety, finance space. The question that you posed, Chair, around how does this all add up? I'll be honest, we've sat with kind of a pencil and a piece of paper and said, right, okay, so we've got a winter additionality proposition. We've got any not meeting criteria to reside that has come down slightly and we expect to come down. And then we've got our other ambitions around the bed footprint, particularly in Furness, and things we might do there, which may have an operational and financial benefit. Trying to square all three of those into a circle right now is largely impossible. What we do know, so the reason for the paper coming is, I guess, the worst scenario is an additionality of circa £880,000. We expect the improvement in not-meeting criteria to reside to eat into that, and we expect the changes that we may make in the bed base and Furness to eat into that. So I guess that's a commitment to we will kind of profligately put in additionality, watch not meeting criteria to decide come down and not offset it. And likewise, as we do things with the bed base and furnace similarly. So that is I guess a key principle of the proposition. But in terms of expediency and worst scenario, I would bring that to the board, and hence the recommendation to Finance and Performance Committee to approve the 862, I think, 882 K.
Okay, we've had the papers, it's gone through the subcommittee, F&P have looked at it. And I'll just check before I ask any question, anything from yourself, Chris, that you wish to add?
Just want to confirm that the ask of the investment isn't an additional investment over and above a provision for in the plan.
It isn't.
Isn't.
Yeah, it's in those, yeah, okay. I'll take questions. Sarah, then Karen.
Thank you. What, in the current financial climate, I know it's in the plan, but it's against a deficit of
22 million.
Thank you. And with other risk-based deficit figures, what's the risk of not doing this, of saying actually we can't afford it? What is the risk of not doing it?
Chris? Mine's a particularly financial response to that. So the forecast that we will look at, we're trying to do the impossible, which was Scott just described, to understand the net impact of the different decisions along this journey. So in our position, we have made an assumption around release of cost associated with reductions in not meet criteria to reside. I don't want to say, however, that is delivered specifically through not doing this. It might be delivered through other pieces of work, and we'll continue to report on that. So there is a presumption that we do take further benefit from not meeting criteria to reside. Based on what Scott's saying, I think it'd be wrong to say today, therefore you don't need a winter plan.
Scott?
So I mean, I think here it's a clinical risk, isn't it? So we've looked at Tabitha and Jane. I mean, this, you'll notice the word performance isn't in the paper here. But certainly what we know is, given the disproportionate demand we face, and given the disproportionate not meeting criteria to reside, seasonal winter, as we've demonstrated in the trust, that knocks over the parameters of safety and quality that we're willing to accept. And so the additionality is pared back to what we believe is the minimum required additionality to secure enough flow to see safe care. It will still see increased congestion, it will still see likely increased ambulance waits, but it's on the basis of, you know, as safe as we can be in the resources that we've got at that time. I defer to Jane and Tabitha.
I'll ask Jane and Tabitha to come in as well, Scott. Jane?
Yeah, so essentially the patients don't know whether we approve this or not. Those patients will still pitch up at our front door. We'll grant to a halt. This tomorrow it would not be safe, I don't think, is my view is we would not be in a safe situation.
To answer your question, Sarah, it's very simple. High levels of corridor care, patient experience will be impacted on, patient outcomes and all the things we talked about in the IPI in terms of maintaining quality patient safety would be a risk. So I actually liked the fact that, I don't know that was the chair or the CEO mentioned something that quality and finance have to be viewed at the same level. So we have to maintain that level of yes, we need to reduce not meeting criteria to reside. We need to improve our efficiencies and everything, but we have to maintain that level of patient safety.
Yes.
Question.
Yeah, thank you. So I think just to be really clear, of course, I support this. It's really, really important. The paper actually doesn't articulate those quality and safety points, though. I don't think. I've just gone back and had a look at it, which is why I asked the question, to be honest. And I just think when we do have to demonstrate that financial probity, that it's just really important that we do articulate that quality and safety risk. So sorry, but that's why I asked the question. So I am supportive, absolutely.
It's a good question. we know you're playing devil's advocate, so. Yeah. The fact that you've had a verbal response from the executive team really will go into the minutes of the board papers, and that strengthens the paper that's gone through the subcommittee to here. So the responses you've given will be in the minutes as that quality issues on that side of the balance really. So I hope that helps.
It does, and I think just when, because inevitably we'll have the same discussion next year, we had a similar one last year. I think if the paper can reflect it next time, that would be really helpful.
Yeah, that's a question I was going to ask at the end, but I'll come back to that. Karen?
Thank you. Yeah, absolutely support the paper and what we've just heard, and agree it's really helpful to be explicit. I'm just really reflecting back to the Quality Assurance Committee recommending to the board that we have a new risk included around the potential impact of GP collective action. And I'm thinking the likelihood of that occurring at the same time as wind pressures is significant. And so what does that potential risk that we've accepted and agreed today mean for this paper, this plan, this proposal? Will this still stand up if the GPs take collective action?
So yeah, as you know, Karen, it's difficult to answer, isn't it? I guess what I would say is that, so at any point, the variables that feed into the urgent care machine, be it demand, primary care demand, population demand, ambulance demand, our own efficiencies within the hospital, not meeting criteria to reside, we calibrate every day. If we didn't get to that escalation level 4 stage in a sustained way, we were gravely concerned around safety and quality, then we'd have different decisions to make. And at that point, we'd be having a very different resource versus safety conversation. I guess in the worst scenario, so if the question is, would you have contingency should that be the worst scenario? We would have physical space. We would not have the current resources. We'd have to have an extraordinary resource conversation. But so I guess we're cited on the variables. We do have some contingency, albeit not resourced, and would be agile as we responded to that. And at that point, would be at escalation level 4, where the nature of the governance and we'll have a different conversation.
I think we should minute as well, with your permission, Karen, because you raised the question. I think as a board, we should minute that, you know, we have excellent relationships with primary care and general practice colleagues, really good partnership work, and really we are really praying and hoping that they will reach a satisfactory solution via the BMA group and the government, because, you know, to be more blunt than you, Scott, we will not be able to cope. And I don't think other trusts anywhere in England will be able to cope if the GPs implement the full catalogue of actions that they could possibly take. That's the answer, really. If any of our general practice or primary care colleagues are listening to the public board, I'd like to say on behalf of the board, please get a resolution, because it's going to absolutely negatively impact on patients.
I'd be really supportive of making that really explicit.
Okay.
Thank you.
Mike, sorry, Tony, then Mike.
Yeah, just to say that we did discuss the whole aspect of the report in terms of the implications, and it was made absolutely clear that not doing this was probably not something to think about doing when you look at the scale of the investment against the overall level of deficit. The other thing which I think is important is about the negotiations around intervention and fiscal support. Our strategy has been to kind of, let's deal with the things we have influence and control over, which I think we're beginning to do quite clearly, and we need to sustain, which puts us in a stronger position in regards to negotiations with region and interventions or support available to us. So there's all those kind of context to add to it. So we did have a big discussion about it, but the conclusion was the conclusion that was proposed here.
Yeah, and you're endorsing it to the board.
Absolutely, yeah.
Okay, thank you. Mike?
Scott, I don't have a vote that would support it. Just Lancashire County Council, I've been following this for a long time. They're giving 4 beds at Lady Elsie Finney House. Are the conversations improving with them? Are they starting to pull their weight more, for want of a better term?
It'd be fair to say relationship and the outputs with Westmoreland and Furness Council are much stronger. The obviously Lancs big county, we're 1/5 of it, so it is. I'll be honest, it's more difficult to secure progress in that space. So that, however, we're trying, and there are some things like the things that are in the paper that we're in the foothills of, but I would say it's been more difficult and less quick than it is with our colleagues in the northern patch.
Right. Supplementary question. Is the ICB assisting with this?
The ICB are fully cited on that through the improvement and assurance group. So the ICB are fully cited on some of the barriers there. Yeah.
There's some discussion going on with Lancaster City Council as opposed to the County Council, which may be of interest.
Just to add to that, we specifically used our submissions into the I&I review to escalate this point. Probably will touch on that set.
Can you just clarify the I&I? I know it's
Investigation. Thank you.
Okay. The paper is being endorsed by the Finance Quality, has raised the balance issues around care. There are 2 recommendations. I'll just check there's no further questions. I'll take each recommendation in turn then. Approve the winter plan as the plan. And secondly, because we approve the plan, therefore approve the appropriate resources up to a maximum, I'll say that again, up to a maximum of 0.882. Okay. Yeah, happy to endorse that, happy to approve it. Chris? Okay, thank you. Scott? Thank you very much. Colleagues, it's a couple of minutes past 11. Shall we have a break till 10 past? Good time for people to get a cup of tea or coffee. Reconvene. Colleagues on Teams will reconvene at 10 past.